Alrighty, everybody. We'll be getting started shortly. I just want to make sure everybody can see and hear me okay. Just do a quick little audio video check. Let me know in that Q&A box if everything is working. You can see the captions. You can hear me. Looks and sounds great. Awesome. Amazing. So awesome. Okay. So welcome guys to our free webinar Wednesday. I am Cait. I'm one of our tutors with Archer Review. And with Archer Review, I've been with Archer for about 2 years now. And I've been in teaching small group sessions, teaching private tutoring sessions, and hosting webinars. We also do a 3-day live review every single month. And so at the beginning of May, the first week of May, we go through every single system that you'll need to know on the NCLEX, and we'll talk to you about all the high yield important stuff, all the pharmacology you need to know for the NCLEX. And I present in cardiac during our 3-day live review. So welcome today. We are going to go through a cardiac case study. Now, these case studies are awesome because they really help test your knowledge. They challenge your critical thinking, and especially with the cardiac system, which is so important, it's going to be a really great case study to go through to get your mind jogging about the cardiac system. Now, my background is in the emergency department and in ICU. And in those settings, we are constantly assessing our patient's cardiovascular system because all of our organ function comes down to adequate perfusion. And if our cardiovascular system is not able to perfuse our tissues and organs well, then we start to see organ failure. And so we're always interested in the patient's cardiac system, how it's doing, and preventing any further cardiac complications. All right. Now, in today's session, we are going to use something called Slido. And if you haven't used Slido before, it's an awesome tool to get, a good idea of what everybody else in the webinar is feeling, to answer some questions, to stay engaged. And so to use Slido, I want you to either scan that QR code there, or you can go at slido.com, use the hashtag cardiacAR, and let me know in Slido, where are you joining from today? So I'm seeing the Philippines, cool, Alabama, nice. Canada, very cool. Montreal, amazing. I'm Canadian. I'm actually from Toronto, so it's always nice to see Canadians at our webinars. Chicago, that's not too far from me. New Mexico, Qatar, very cool. Kenya, amazing. I was in Kenya in January, and it's an amazing place. I loved it. Windsor, very cool. New Mexico, Florida, Tampa. Yeah, this is awesome. The cool thing about being involved with Archer is seeing so many students from around the world. Toronto, hi. Hopefully our weather's going to start getting better. Hey, I'm ready for some sunshine. Cool. Brazil, amazing. Well, thank you guys so much for joining wherever you are in the world, especially those of you in the Philippines. I know it's late. I know you're probably tired, but just stick with it for another hour, and we'll make this fun. I promise. I'll help you stay awake. Awesome. Another person from Kenya. Very cool. Alrighty, so it looks like you guys have gotten Slido. We're going to use this throughout the session, but only when we are using a Slido slide. So I'll let you know. And usually on the left side there, you'll see something that says Slido. That's how you know you're going to be using this. I find it's really helpful to either join the Slido on your phone or use it on your computer as you're watching the webinar. It just makes it nice and easy for you guys to participate. Ooh, from Hawaii. I love Hawaii. Hawaii was my first love. All right, let's get going. So when it comes to our cardiac system, our bread and butter is the blood flow through the heart. And I know so many students are struggling with the blood flow through the heart, so I'm going to help you through this. And by the way, guys, this free webinar is kind of a way for you to get a taste of how we teach at Archer. Now, what I'll tell you is Archer is really we're really committed to understanding the why and teaching the why, because once you understand the content and the pathophysiology, that's going to help you answer those really difficult difficult NCLEX questions a lot easier. So you'll notice during the session, we're going to be talking a lot about the why. Now, part of understanding the why is understanding how the circulation moves through our body, how our blood flow moves through our body. And this is a nice little infographic to show you how it works. Now you can see that we have two sides of the heart. We have the right side of the heart, which usually deals with deoxygenated blood. And then we have the left side of the heart here that usually deals with oxygenated blood. And they're kind of systems that are separate, but they work parallel and they kind of work together. So as that heart pumps, both the right side of the heart is pumping and the left side of the heart is pumping. Now, let's get through this blood flow through the heart. When I'm thinking about the blood flow through the heart, I always start at the body. And that just makes it easy to think about because I know that at a systems level, the body is where the tissues will use up all of the oxygen in the blood. And now the blood becomes deoxygenated. Once the blood is deoxygenated in the body, think about where it wants to go. It wants to go to the lungs in order to pick up more oxygen, right? Now, there's no direct pathway to go from the body to the lungs. We have to stop at the heart first because that's the center of our circulatory system, and that is our pump. So from the body, we take some blood vessels to get to the right side of the heart. Now, can you think, are we taking veins or are we taking arteries to get to the right side of the heart? Let me know in that Q&A box. Are we taking veins or arteries to the right side of the heart? What do we think? Yeah, awesome. We're taking veins, right? Because veins go towards the heart, and we're going towards the heart here. So we're taking veins, and that will be the superior and inferior vena cava. Those are the big veins that bring blood to the right side of the heart. That will bring the blood into the right atrium. Then the atrium will contract, move blood into the right ventricles, and then take the pulmonary artery towards the lungs. Now, this pulmonary artery is special because this is the only artery that's carrying deoxygenated blood. Now, when you're thinking about whether it's an artery or a vein, I want you to think, are we going towards the heart or are we going away from the heart? So for example, when we're looking at this pulmonary artery, we're getting blood from the right ventricle, moving away from the heart towards the lungs. So if we're going away, I always think away. So it is an artery. And we're going towards the lungs, so it's the pulmonary artery. Okay. At the level of the lungs, gas exchange is going to occur. We're going to absorb more oxygen in the bloodstream, and we're going to get rid of that carbon dioxide. And then we want to go back to the body so that perfused oxygenated blood can be useful again. But of course, we have to stop at the heart first. So from the lungs, we're taking a blood vessel back towards the heart. And of course, because we're going towards the heart, it's a vein. We take the pulmonary veins into the left atrium. Atrium will squeeze blood into the left ventricle and then move blood through the aorta into the rest of the body. Now, the aorta is a massive artery in our body. It's going away from the heart. So remember, it's an artery. And this is the mother of all arteries, I like to say, because it stems from the left ventricle and it goes all the way down, kind of down to your umbilicus, where it will bifurcate or split into your two femoral veins. And in fact, all arteries in our body will stem from this major blood vessel, the aorta. Okay, so this is the blood flow through the heart in a nutshell. Big tips I have for you here is remembering that the right side of the heart deals with deoxygenated blood. The left side of the heart deals with oxygenated blood. And whenever you're naming, whether it's a vein or an artery, I want you to think, are you going away from the heart or towards the heart? All right, so that's blood flow through the heart in general. Does anybody have any questions before we move on to our case study? So for the NCLEX, I want you to know this. I suggest students don't attempt the NCLEX unless you can understand this. once you understand the blood flow through the heart, it makes understanding the pathophysiology of things like heart failure and things like congenital disorders, congenital heart disorders, really, really easy for you to understand. Okay, so let's get moving into our case study. I'll let you know who this client is. So we're a nurse working in the emergency department, and you admit Mr. Brown, who walked into the ER with his wife. He's a 62-year-old male with a past medical history significant for type 2 diabetes, for which he takes metformin, hypertension, for which he takes an ACE inhibitor, hyperlipidemia, he's not really on any medications, and he currently smokes half a pack of cigarettes per day. He doesn't have any allergies. He arrives with primary complaints of chest pain, shortness of breath, on exertion, and nausea. Now, here's a Slido slide. You can see it's at slido.com. Tell me in Slido what concerns you about our client. What are some things in that little introduction of the client that is concerning to you? Shortness of breath. Yeah, for sure. The fact that he's smoking. Yeah, definitely. Untreated hyperlipidemia. That client's having chest pain. You got it. Definitely. So chest pain and shortness of breath are definitely the two symptoms that are very concerning here. And looking at his history, the fact that he's a smoker, he has diabetes, that definitely puts the client at risk for cardiovascular disease, right? I always imagine things like smoking, uncontrolled diabetes, and uncontrolled hypertension, kind of like they're disorders or factors that will rip up the inner lining of your blood vessels, and it causes so much damage along the way. And that's why it's really important to educate clients on stopping smoking and reducing their blood pressure levels, because those significantly contribute to cardiovascular disease. When those blood vessels are damaged, plaque can form, atherosclerosis can form, and those are just precursors to cardiovascular disease. Awesome. So you got it. We know we're pretty concerned about Mr. Brown here. Those chest pain, shortness of breath symptoms are going to be more concerning. So let's talk to Mr. Brown and get a bit of an idea of what his pain is like. So we ask him, have you had chest pain like this before? And he says, I used to, but only when I exercise. Now it's even when I'm sitting down. Tell me where the pain is exactly. Can you point to it? And he says, it's in my chest and my left arm. On a scale of 1 to 10, how bad is it? I would rate it a 6 out of 10. All right, let's take this back to first year nursing school. Is this a subjective or an objective assessment? What do you think? Yeah, Whitney, Brian, awesome. Jacqueline, yeah, this is a subjective assessment where we're asking the client questions and the client is telling us some stuff about his symptoms. That is definitely a subjective assessment. Objective assessments are where we use our clinical assessment skills to find symptoms ourselves. Okay, so we know a little bit more about his pain. Now, let's move further in our objective assessment here. So we're obtaining vital signs and we're doing that objective assessment. When we check out his vital signs, his heart rate is 110. The blood pressure is 176/82. His O2 sats are 89% on room air. That respiratory rate is 26, and his temperature is 37.9 Celsius. When we're doing our head-to-toe assessment, neuro, he's alert and oriented, he's anxious, and he's complaining of that chest pain. Remember, pain goes under your neuro assessment typically. Respiratory-wise, he is tachypnic. Remember that respirate is 26, and we're seeing diminished lung sounds. Cardiac, he's hypertensive. We can hear S1 and S2 sounds, so that's good. And radial and pedal pulses are palpable at +1. The abdomen is soft. His last bowel movement was yesterday. He's complaining of nausea, but he's not vomiting. And he has hypoactive bowel sounds. GU, he last urinated 1 hour prior to arriving to the ED. And lastly, skinned, no open wounds, and he appears a little sweaty. Okay. Hop on Slido again. I just want you guys to join. We're going to do a quiz based on those assessment findings. So think about those assessment findings. Yep, you guys are joining here. Awesome. Jillian, Mary, Rain, you got it. Cool. Just waiting for some more people to join here. The code for Slido is #cardiac_AR. Awesome. Let's see if we can get 30 to join. Great. Okay. So this is our quiz question. Based on your initial assessment, what findings require immediate follow-up? Select all that apply. So what's concerning for this client here? The heart rate, the blood pressure, oxygen saturations, chest pain at rest, urinary output, or that temperature? Remember, if it's asking us what requires follow-up, it's asking us what's concerning, what is abnormal. Nice. So most of us are saying heart rate, blood pressure, oxygen saturation, and chest pain at rest. Now for Mr. Brown here, we are concerned about his blood pressure, O2 sat, and chest pain. His heart rate was a little bit elevated. It was about, I think, 110 beats per minute. But that's not too concerning, especially if he's complaining about pain. I'm not too concerned about that. But what I am concerned about is his blood pressure, oxygen saturation, and his chest pain at rest. Now, I'm sorry. Just to go back here, this is our leaderboard, and we have J3 here in first. We're going to go through a couple Slido questions, and we'll see who comes up at the top at the end. Okay, so we've assessed Mr. Brown, and we noticed his blood pressure was super elevated. His O2 sat was low, and he is having that chest pain at rest. Now, whenever you're having a client with chest pain, I want you to be concerned, especially if they're short of breath and those sats are low, because that's telling us that the ABCs are potentially compromised here. So, next quiz question. Based on the current assessment findings and vital signs, what do you tell the provider that you suspect the client is experiencing? So what's our most likely diagnosis? AFib, COPD exacerbation, myocardial infarction, or pericardial effusion? What do you think is the most likely diagnosis here? Seeing some sweet, very good answers in the chat here. Awesome. Yes. So most of us are saying we're worried about a myocardial infarction, right? This is going to be our most concerning diagnosis because, again, that client is complaining of chest pain. Ooh, J3 is still in the lead here. Cool. So that client was having chest pain, especially at rest. We are worried about a myocardial infarction. Now, we don't really have enough information to completely diagnose this, but we're going to do something first before we proceed with MI treatment. So now, just before we get to the next question, let's imagine Mr. Brown's pain was that left arm pain, and maybe he said jaw pain as well, but he didn't say chest pain. Would you still be worried about an MI? So if Mr. Brown just complained of that left arm pain, maybe he said jaw pain, would we still be concerned about an MI? Whitney says yes, and that's 100% true. Because clients who are elderly or are female, they tend to have these atypical signs of an MI. So whenever our client is elderly or female and they're complaining of arm pain or jaw pain, or maybe indigestion, for example, those are still symptoms that you should be concerned about and be considering an MI in that client. Okay. So whenever you identify that, which diagnostic tool would you expect to be done stat? 12-lead ECG, an echocardiogram, a Doppler ultrasound to assess for blood clots, or a CT scan of the abdomen and pelvis. So we have a client complaining of chest pain and arm pain. We've identified that we're concerned about an MI. What's the first thing we want to do? Yes, we want to be doing that 12-lead ECG. Okay, we always need to prioritize this 12-lead ECG in clients who are complaining of chest pain. Echocardiogram is so echo is like the ultrasound, and that's echocardiogram is the heart. So we're doing an ultrasound of a heart when we're doing an echocardiogram. This probably will be done at the bedside, but it is not our priority in our clients experiencing chest pain. Our priority for clients experiencing chest pain is always going to be an ECG. Okay. The NCLEX might ask you these priority setting questions. It might say, which intervention will you do first? And anytime our client is complaining of some sort of chest pain or arm pain, or we're worried about an MI, we should always be doing this ECG first, because that will tell us whether or not our client is having those ST elevations. If we see ST elevations, then we're worried about a STEMI, and that is a big deal, because that tells me their heart tissue is dying. It's a really, really bad situation. So in order to determine what that next hour is going to look like for our client, we have to do this ECG. Now, how would you explain the process of getting an ECG to Mr. Brown? Let me know in the chat box, or just think about it to yourself. Mr. Brown asks you, hey, I've never had an ECG before. What does that mean? What does it do? Well, how do we obtain an ECG? Yeah, Whitney says we place leads on the chest to see how the heart is working. Yeah, we're seeing the activity of the heart. Exactly, Nadia. It helps us monitor the heart rate. Good. Ooh, Kelsey says measures the electrical conduction of the heart by placing leads on the chest. Exactly. So, Mr. Brown, since your primary symptom today is chest pain, we would like to get an ECG. An ECG, or an electrocardiogram, will take a picture of the electrical rhythm of your heart from multiple different angles. And in order to do this, I'm going to place stickers on your arms, legs, and chest, hook them up to wires attached to a machine. It will be done in just a couple of minutes, and you won't feel any pain while it is being done. Do you have any questions? I always like to end any sort of explanation with, do you have any questions? Because sometimes the client may not be clear, maybe you used a lot of medical jargon, and it's a good way to make sure the client is understanding you properly. So ECGs are really cool. I think they're really interesting. I don't know how you guys feel about them, but I think they're so cool, because the heart is a really special organ, and not only can it create a mechanical contraction, but it actually can generate electrical impulses all by itself. And a fun fact about a heart is that if you remove the heart from a client's body and it's just out there sitting on a table, for example, as long as it has oxygen, it is still able to beat all on its own. It doesn't have to connect to the nervous system. It can just generate its impulses all on its own and beat basically on its own as long as it has oxygen. It's very cool. And so when we are doing an ECG, you're right, we're placing stickers on the chest, and those stickers kind of act like a camera, and they observe and monitor the electrical activity of the heart and essentially paints a picture of that electrical activity on the monitor. Yeah, and someone says ECGs are hard on me for sure, and ECGs are challenging. If you need help with ECGs, our private tutors are awesome, and they will help you explain every single step to interpreting ECGs. We have sessions available every single day, every week, and they are about 1 hour each, and they cost $75. Now, maybe it's not ECGs that you have questions about, but it's something else NCLEX related that you have questions about. Or maybe you have a list of questions that you're just like, I'm not sure I want this to be answered. You could book a private tutoring session, give that tutor all of your questions, and they will answer it for you. They will go through concepts with you and make sure you're understanding. At the end of the session, they'll create a study plan for you. So if you're like, I don't know how to study, I've maybe failed the NCLEX before and I don't know what's going to work for me, they're awesome and they will help you create a plan. Yes, thank you, Rachel. And she just put that tutoring link there in the chat box. So at that link, you can see how you can book and any other information that you need. Okay, let's get back to our case study. So when we do the ECG for Mr. Brown, we are seeing this. What are we thinking here? What is the concern? Why don't we try out this question? What does that ECG show? Are we seeing ST elevations, a prolonged PR interval, a normal ECG, or bradycardia? Hmm. 8 seconds left. What do you think? Yes, 86% of us got it for sure. We are seeing ST elevations in that ECG, and that is definitely a concern. So let's go back here. This is our ECG, and you'll notice that in our ECG, we are seeing a P wave, this QRS complex, this ST segment, and then it comes back to that P wave. And so when we see this, the first thing that I'm noticing is this ST segment that is elevated. So this is the isometric baseline here. And usually your cardiac rhythm will come back down and then your ST segment should be around that isometric line. But do you notice that here we are seeing an elevation of that ST segment? So right after that QRS complex, we see that segment elevated. And in fact, if you were to look at this, it almost kind of looks like a tombstone, right? So if you're seeing in that tombstone in the ECG, that's a cause of concern for an MI. And this is one type of an MI, which would be called a STEMI, ST segment elevation MI. So in a STEMI, we are seeing this ST segment elevate, and that makes me concerned about heart tissue dying. Because when I say the words MI, myocardial infarction, the word infarction means cell death. And so if we are identifying an MI in the client, that means that the client is having cell death in their heart. Their heart cells are dying. And if those heart cells die, it's a bad situation because those cells can't contract well. Those cells can't conduct electricity well. And your client can end up in a really bad situation really, really fast. Some students were talking about the PR interval here. Now, this is the PR interval from the beginning of the P wave to the beginning of their QRS, or where it just starts to turn. And this looks normal to me. You can see it's about 3, maybe 3.5 boxes in length. And that tells me that that PR interval is normal. Again, if you need more help with EKGs, you can book a private tutoring session, or I run ECG sessions in small group form if you're interested. Oh, good question here in the chat box. Somebody's asking, when do we see an NSTEMI in an ECG? Good question. So when we are seeing an NSTEMI, you would not see these ST elevations. You might see a normal ECG, or you could see ST depressions. So instead of that ST segment being elevated, it's going to go way down past the baseline and then make that ST segment and then come up to a T wave and then your P wave again. So this is what we would call a depressed ST segment, and that makes us worried about a potential NSTEMI. So this ST segment is not elevated, instead is depressed, or sometimes you can even see T wave inversion. Guys, what about an angina? What ECG findings would we see in angina? Would there be changes or would it be normal? What do we think? Kelsey, you got it. Brian, you got it. Pam, nice. So in angina, you would see a normal ECG, okay? In angina, we would see a normal ECG. So it would look completely normal, normal sinus rhythm, and there would be no changes in the ST segment or the T wave. So that's what differentiates between the three kind of chest pain presentations. We have an MI, which would have ST segment elevation. We have an NSTEMI, which would either be normal or have ST depression or T wave inversion, or we have angina, which would be completely normal. Okay. And this is why we're doing the ECG, guys. This is all the reason why we hooked this client to the monitor, because I want to know if that client with chest pain is presenting with heart cell death or they're just presenting with ischemia. I am much more worried about that infarction. And so the only way I can tell how my client is going to be treated in the next hour is by doing that ECG. Okay. Any questions about ECGs? I know they're hard. Hopefully that helps kind of going through the different kinds and what we see in the ECG. And this is why we prioritize it, because again, it helps us determine what's happening with our client. Great. So now we have received the following orders from our primary healthcare provider. Which one should we be doing? So this is going to be a select all that apply. A, administer morphine 2 to 4 milligrams IV PRN. B, administer nitroglycerin 0.4 milligrams PRN for chest pain to be dissolved under the client's tongue, and you can give 3 doses. C, supplemental oxygen via nasal cannula for O2 sats less than 90. D, draw serum lab test, specifically a troponin level. Or E, administer 325 milligrams of aspirin. Okay, so let me know in Slido what we think we should be doing. Which orders does the nurse recognize as essential, and which ones should we implement immediately? Seeing some nice, awesome answers in the chat here. All right, what do we think? Okay, so our correct answers here are actually B, C, D, and E. Okay, so we want to give nitroglycerin. Nitroglycerin is a vasodilator, which will dilate those coronary arteries and hopefully get more blood flowing through them. We're going to give oxygen, especially if that client's oxygen levels are less than 90. We want to maintain proper oxygenation. We need to draw serum lab test, specifically that troponin level, and we need to administer aspirin. Oh, Gurpreet took the lead here. Okay, so why are we doing this? Now, when it comes to doing these things, we're always going to try to maintain oxygenation of the heart and to decrease the workload of the heart. And we would consider giving aspirin. Now, what kind of medication is aspirin? Think about it. Aspirin is an antiplatelet medication, right? And a lot of the time when we're seeing an MI happen, it's because a clot that might be formed in the client's coronary vessels. And so if we give that client an antiplatelet medication like aspirin, it's going to prevent that clot from getting any bigger. And sometimes we've actually seen aspirin have the ability to kind of dissolve the clot completely. And so aspirin's a really, really great drug that we're going to be giving in clients who we're worried about MI. Troponin levels are going to be important here. Now, this troponin level is a blood test that we can do for anybody experiencing some sort of cardiovascular issue, especially if we're worried about an MI. Now, remember how I said in an MI, we're talking about infarction, which tells me cell death is happening. And so if there's cell death of the heart, those heart cells will burst open and will release its contents into the bloodstream. And part of the cell contents in the heart cells is troponin. Now, so if we're seeing troponin detectable in the bloodstream, that tells me cell death in the heart has been happening. And you might wonder, why aren't we giving morphine? So morphine can be given in clients who maybe are still having chest pain after the nitroglycerin. I would maybe assess that blood pressure first, but it's not really going to be our priority treatment here. I would want to prioritize nitroglycerin because it also has that vasodilating effect first and see if that resolves the chest pain. Awesome. So let's reassess our client after these interventions while we wait for some labs to result. So we've taken a troponin, we've taken other blood tests, and we're waiting for the result. We see Mr. Brown here, and his heart rate has come down to 90. Great. His blood pressure has now come down to 132/64. His O2 sats are 96% on 2 liters by nasal cannula. His respiratory rate is 20, and his temp is 37.6. And when we talk to Mr. Brown again, I say, after taking the nitroglycerin tablet, how is your chest pain feeling? My pain has improved. It's a 3 out of 10 now, and I'm also feeling less anxious. Awesome. Since I'm able to give you the nitroglycerin every 5 minutes for chest pain, I'll give you another dose to see if we can get that pain to go away completely. Okay, sounds great. What are some side effects that we might warn Mr. Brown of because we're giving him nitroglycerin? So what are some side effects of nitroglycerin that we should educate the clients on? Ooh, Ava says headache for sure. Headache is a main side effect that we might see because not only does it dilate our coronary vessels, it's going to dilate the vessels in our brain. So it causes a big rush of blood flow to the brain, and that will cause a headache. And it will cause hypotension as well. Amazing. You guys are so smart. Because of the vasodilation that occurs, we have the same amount of blood volume in a larger diameter vessel, and that will drop that blood pressure. So especially for giving those 3 doses of nitroglycerin, I'm going to look at that blood pressure and assess it. I might expect it to be a little bit lower. Okay, now Mr. Brown's labs have resulted, and take a look here. We have our normal lab values here, and then we have the values of Mr. Brown at the top. And you can see in the red things that are outside of normal. Now remember, on that next-gen NCLEX, thank goodness they have given us normal lab ranges, so we don't have to memorize them anymore. So that's sweet. But we're seeing some abnormalities here. Problems with the cholesterol I'm seeing. That troponin level is elevated. It's 329. So that is indicative of heart cell death. Glucose is elevated here, and the hemoglobin and platelet levels are a little bit off. By the way, guys, in clients who have angina, what will their troponin level be? Will it be elevated or will it be normal if the client had angina? Nice, Ravnit, Kelsey, awesome. So in angina, you see normal troponin levels. In chronic stable angina, we do not have cell death. It doesn't have that word infarction to it, so there is no cell death, okay? What's happening is ischemia, decreased blood flow, but it's not completely blocked, and so we still have a normal troponin with angina. So in angina, the client will have chest pain, they'll have a normal ECG and a normal troponin level. In clients with an infarction, especially a STEMI, they will have those ECG changes and will be seeing elevated troponin levels. Okay, so here's our next question. Of those results, which are the priority to report to the provider? Select all that apply. So we took a look at his lab values, and now we're trying to identify which one is a priority for us to report. Which ones are quite concerning for us? What do we think? This one's a bit of a tough one. Okay. So the ones we're concerned about here, definitely that troponin level. 98% of us got that. We know that because if that troponin is elevated, I'm worried about cell death, okay? Cell death is definitely a concern of the heart because it's not going to be able to produce cardiac contractility strong enough. It's not going to be able to conduct electricity well. Now, the lipids are also a concern for us here. Because they were elevated. And we know this client has hyperlipidemia that's untreated, and that could be contributing to our client's symptoms. Oh, Gurpreet is the one who ended up on top here. That's awesome. Very good. Congrats. Now, going back to this question here. We see the troponin level and the lipid level elevate, especially with this client who has uncontrolled or untreated hyperlipidemia. We're concerned about it because those lipids, those fat globules, can plug up our arteries and block perfusion of our blood vessels. Hemoglobin was a little bit low, but not low enough for us to transfuse a client. So it's not too much of a priority for us to alert the provider of. And that glucose level, again, was elevated, but hyperglycemia in our acute stages here of an MI is not too much of a concern. When the body is under stress, it releases glucocorticoids and cortisol levels, and it will cause that glucose level to elevate. All right, so after discussing the ECG, the troponin level, and the client's overall presentation with the provider, a plan is made to immediately transfer the client to the coronary cath lab for assessment of those coronary arteries, right? Because we saw those ST elevations on the ECG, we saw that positive troponin level. During this assessment, it's likely that the provider in the cath lab will find severely occluded coronary arteries due to the ECG and troponin levels. Therefore, we can expect a PCI to take place during the procedure. Now, this is where a catheter is placed through a peripheral artery, typically the radial artery. I've sometimes seen it in the femoral artery as well. And a stent is placed in that affected coronary artery to restore blood flow. Now, if the stent is unable to be deployed, the client may require a CABG, which is a coronary artery bypass graft, which is a form of open heart surgery. You and the provider will enter the client's room and explain this process to the client. And remember the standard care of door to PCI in 90 minutes. Now, this is a universal goal for clients experiencing an MI. So let me show you what a PCI looks like. So when it comes to our coronary vessels, these coronary arteries, remember it's an artery, it's perfusing the heart tissue itself. So it's providing oxygen, blood, and nutrients to those heart cells. Now, what happens because of hyperlipidemia, because of smoking, because of diabetes, it can cause atherosclerotic plaques to form in these coronary arteries. And because the lumen of the vessel is narrowed by these plaques, blood can get stuck and it can form a clot. And it can completely occlude that vessel, so completely restrict blood flow to those heart tissues. And that's why infarction occurs. That's why they die, because they're not receiving any oxygen. Now, once we've identified that client having an MI, we want to get that client to the cath lab to get this PCI done as soon as possible. And the standard goal is going to be within 90 minutes. So as soon as the client presents with that MI, we want to get them to the cath lab within 90 minutes. Now, in that cath lab, like we said, we're going to puncture an artery, usually the radial artery, and take a wire and kind of snake it all the way up into the heart through the aorta to find those coronary vessels. It will find this diseased coronary artery where there is plaque buildup, and it will deploy this balloon, which will inflate and push that plaque to the sides. And now you can see that the occlusion has been fixed. That vessel is now patent. We have reestablished blood flow, and typically these clients will end up with a stent afterwards to prevent that plaque from occluding the vessel again. Okay, so this is kind of our gold standard of treatment. It is very minimally invasive. There's not that many complications to it, so it is a great option. Now, in that explanation, we also talked about a CABG, which is a coronary artery bypass graft. This is usually done for clients who have maybe really significant occlusions in their coronary arteries, or maybe the coronary artery can't be accessed by that PCI. And so they might have to do something more invasive called a CABG. And like it said, it's an open heart surgery. So what are some complications that might occur with CABGs? Yeah, bleeding for sure could be a concern. After a CABG or any open heart surgery, the client's at risk for cardiac tamponade. So that can definitely occur. Other things that might happen is an infection. Or maybe even kidney damage. That's another big one that can happen when we're doing any sort of interventions with the heart. When we're doing a CABG, we're creating new pathways for blood to flow. So we're going to bypass those damaged and blocked coronary arteries and use a different artery like the internal mammary artery sometimes, or the saphenous vein sometimes, to bypass those damaged vessels. Now, in order for us to do that, we kind of have to clamp off the aorta in order to, keep the heart from. So in order for the physician to do that procedure properly. But if we stop and clamp the aorta, we're not getting any perfusion to the distal extremities. We're not getting perfusion to the kidneys. So we end up seeing a lot of kidney injury or AKI after a major surgery like that. So that's why we prefer a PCI. This is our gold standard. This is usually what we're going to be doing or seeing for our clients, again, because it's minimally invasive and does not have too many complications associated with it. Now, after our client's PCI done, what are we going to teach them to do? Well, we'll teach them to stop smoking. That is a big deal. And especially adjusting their diet, because those two things contribute to the plaque buildup and contribute to the atherosclerosis that can occur. We'll get our client to exercise, usually something nice and aerobic like hiking or jogging. That's really helpful for the cardiovascular system. After the procedure, we're going to encourage the client to take medications. Typically, they'll be on aspirin, and they'll also be on a platelet deaggregator like clopidogrel or Plavix. This is really important to take because we have that mesh stent in the heart now. And because it is meshy, it is a really great place for clots to form. So for the first year after the client's MI, they'll take an antiplatelet medication to prevent any clots from forming. If you don't take your clopidogrel or your aspirin after your MI, then I've seen clients end up having an MI again, like really shortly after, a few months after, they'll have another MI because clots have built up in that stent. And then we're also going to think about, of course, treating that hyperlipidemia because that client wasn't treated before. And post-procedure, we're going to take a look at that site, take a look at that radial artery, take a look at that femoral artery and make sure that it's not bleeding. Because remember, arteries have huge amounts of blood going through it, a lot of pressure going through it. And so we're definitely going to be concerned about bleeding in that case. Awesome. So that is the end of our case study. I just want to introduce you to our SurePass program, which is our #1 product here with Archer. This is a program that is best for students, if you are feeling like you need extra support, especially if you've taken the NCLEX before and were unfortunately not successful. This includes the QBank, it includes lectures with our awesome instructors, and it includes a 3-day live review access. So you get access to those 3 days where we review everything for the NCLEX. So take a look at those QR codes to scan if you are interested in that product. Now, before we leave, do you guys have any questions? Oh, what's happening here? Any questions that you may have? Somebody said, I'm confused after CABG or PCI. Do we have bleeding and cardiac tamponade? So after a CABG, we are at risk for bleeding. We're at risk for cardiac tamponade. We're at risk for renal injury. After PCI, there's not too many complications. We'd mostly be worried about bleeding at the puncture site. Can I explain again how that PCI is done? Yeah, for sure. Let me just go back again for a second. So when we are doing a PCI, we identify that there is a coronary artery that is blocked by some sort of plaque and a clot. And so what the physician will do in a PCI is puncture a radial artery or access the radial artery or femoral artery, bring a wire all the way up through the arterial vasculature into the aorta and then into the coronary vessels. We will identify that diseased vessel and they will deploy a balloon where the blockage is. And that balloon will push the plaque to the side. It will get rid of the clot, and then a stent will be left to reestablish patency of that blood vessel. So that is how a PCI is performed. All right, let's see what other questions we have here. Sometimes we see a U wave in the ECG. Why is that? Usually you would see a U wave in hypokalemia. So low potassium levels are most commonly when we would see a U wave. I took Archer Review for the first exam and it's expired now. If I take Archer SurePass, the QBank would be the different or the same. It's possible it wouldn't be different. What I would suggest you to do is email support@archerreview.com with that question, and they can answer you and help you with that. What material is the stent made of? It's made of metal. It's just a little mesh, little metal mesh. And so that is kind of how that stent is formed. Any other questions here? Why does the patient get dual platelet medications? It's really important because that mesh that is left there, again, is metal, and it is a really great environment for little blood cells to get stuck in it, and then those clots can form again. So without those dual platelet therapy, clots can form, and we can get actually a clot in the stent, and it makes it much more challenging to treat if that happens. CABG stands for coronary artery bypass graft. Did you say CABG was the one at risk for cardiac tamponade? Yes, because it's an open heart surgery, that pericardial membrane can get nicked, and that can cause a cardiac tamponade to occur. Can you still do a PCI or CABG if the patient is a high risk for bleeding? For sure. We really are going to prioritize preventing the death of those heart cells, right? We can treat bleeding. We can give IV fluids. We can give PRBCs. We can't reverse that cell death, the heart cell death. And so we're definitely going to prioritize these procedures and then deal with any sort of complications that might occur afterwards. Okay. What about PCI? Are they at risk for cardiac tamponade? Probably a much lower risk. Somebody's asking me to explain a cardiac tamponade for sure. So bear with me in these drawings, but let's say this is our heart, right? And our heart is an organ, but it is always covered with a membrane, right? And the heart's membrane is called a pericardial membrane. And it moves with the heart, right? It protects the heart. However, if that membrane were to get disrupted, I'll see it all the time in the trauma bay. You see it in clients who have open heart surgeries. That membrane can get disrupted, and then it can cause blood to pool in that pericardial space. And if blood pools in that pericardial space, it's going to start to put pressure in the heart. And it's actually going to start to squeeze the heart a little bit. And it starts to obstruct the heart. And now the heart kind of almost shrinks because there's all this pressure around it. And it's not able to expand and contract as well. And so now we're having troubles moving blood forward. We're having troubles with cardiac output because now this heart is not able to move. Okay, that's essentially what cardiac tamponade is in a nutshell. Is there a chance that a patient may develop arrhythmias after CABGs? For sure, especially after any sort of heart cell death, after any cardiac activity that happens. Whenever heart cells get disrupted or have any changes in blood flow, that's when arrhythmias can happen. Because arrhythmias is all just what's happening is an interruption in the electrical conduction of the heart. So anytime that heart is stressed, we're at risk for arrhythmias. Is it through the femoral artery for the PCI? Yes, it's through the femoral artery or the radial artery. And yes, let me go back to the blood flow through the heart again. I know this is hard stuff. So when it comes to blood flow through the heart, we have our deoxygenated blood first in our body, right? And then it takes the veins to go into the right side of the heart. So we'll take the superior and inferior vena cava into the right atrium. Blood will move through the right heart, so through the right atrium, through the right ventricle, into the pulmonary artery to get to the lungs. Because remember, this deoxygenated blood is looking for more oxygen. At the level of the lungs, gas exchange will occur. And now the oxygen will be in the bloodstream. It will move the blood through the left side of the heart. So it takes the pulmonary veins to get to the left atrium, into the left ventricle. And then those ventricles will squeeze and move the blood into the aorta, which will then circulate that blood throughout the body. How to manage a tamponade. Really, we're going to try to promote oxygenation of the client as much as possible, but the definitive treatment for it is to get something called a pericardiocentesis done. So pericardiocentesis. This is essentially where they'll go into that pericardial space and aspirate any of the fluid there. Okay. Now, what I want to show you guys quickly before we say goodbye is how to book small group sessions with Archer Review. So if you go to archerreview.com, just take a little second to load, you can go to our nursing portion of Archer. So you'll like to go to the NCLEX RN, and then at the top, you'll find this private tutoring tab. And then you'll go to the NCLEX tutors. When you scroll down, you'll see what we have available for the week. So every yellow dot tells me there's a session available, either a small group session or sometimes even a private session that might be available. You just have to kind of go over there. If you want to look at what sessions I have available upcoming, then you can go through our tutors here and then check out Book Now. You can see a little bit about me, and you can see my schedule coming up. So on Friday, I am teaching pharmacology memory tricks and test taking strategies. These small group sessions are $25 each, and they last for an hour. We have up to 20 students in each session. So it's a great little resource because you can still ask questions. I can interact with you better, and but you still get kind of the more affordable option here. In pharmacology memory tricks, I share every trick I have for pharm and helps you remember things like insulins. And we talk about digoxin a lot. Any high yield med on the NCLEX, we're going to talk about it in pharmacology memory tricks. And then in test taking strategies, we'll be talking about different strategies you can use to tackle those NCLEX questions, especially if you're like stuck in between two and then you get the question wrong. That's a great session for that. And if you want to practice your cardiac system a little bit more, we have another case study in cardiac disorders and assessment where we pretend to be an emerg nurse again. And it's a great session for you to review your critical thinking and to review your cardiac knowledge. If you book more than 3 sessions, whether it's with just me or mixed with other tutors, you can get a little discount. So if you're interested in taking 2, you might as well take 3 because you can get a little discount. Somebody's asking about ECGs. I do host an ECG session. When is my next one? That's a great question. Oh, not for a while. I guess that's May. Oh, here. The next one is May 23rd. If you're interested in an ECG small group session, I can always open one. If you go to kate.kappa@archerreview.com, email me, let me know you're interested, and I'll open one for you. And I'll work with your schedule to make sure you're able to attend. Awesome. If you have any other questions, we'll stick around for a little bit to answer, but thank you guys so much for joining. I hope you found this helpful in improving your cardiac knowledge and understanding the pathophysiology of the heart. Again, you have my email there if you have any questions. Thank you guys, everybody. Good luck on the NCLEX and all the best. Have a great week.